In emergency medicine, you see the end of stories that began quietly years earlier in the most ordinary moments of ordinary lives. You see the 58-year-old who thought his headaches were just stress. The 63-year-old woman who knew her blood pressure was slightly elevated but felt perfectly fine, so never really addressed it. The 49-year-old who had been meaning to sort it out, to book the follow-up appointment, to take the medication more consistently, and then one Tuesday morning, without any warning at all, the story reached its conclusion in the back of an ambulance. Hypertensive stroke, hypertensive heart failure, aortic dissection. These are not rare dramatic events reserved for the unlucky. They are the predictable, measurable, largely preventable endpoints of one specific mistake that is so deeply embedded in modern life that most people making it have absolutely no idea it is happening. The mistake is not what most people assume it is. It is not simply having high blood pressure. It is the way that millions of people measure, interpret, and subsequently act on their blood pressure readings, and the profound, clinically significant gap between what those readings actually show and what people believe they show. This gap is not a minor technical detail. It is the reason that hypertension kills at the rate it does, despite being one of the most detectable, most treatable, most thoroughly researched conditions in the history of medicine. The information exists, the tools exist, the treatments exist, and yet 1 in 3 adults has high blood pressure, roughly half of those are inadequately controlled. And a significant proportion of the cardiovascular damage accumulating in the population right now is happening in people who genuinely believe their blood pressure is being managed. So let us be very precise about what this mistake looks like, why it happens, what it does to the body, and what actually needs to change. The most common blood pressure mistake made by millions of people every single day is this. They treat a single blood pressure measurement as though it represents the truth about their cardiovascular health. One reading taken once, at one moment in time, under one set of conditions, and then filed away as either reassuring or concerning, with an entire clinical picture built on that single data point. This is a fundamental misunderstanding of what blood pressure actually is. Blood pressure is not a fixed number, it is a dynamic, constantly fluctuating physiological variable that can shift by 20, 30, or even 40 millimeters of mercury within minutes in response to an enormous range of stimuli: physical activity, emotional state, temperature, hydration, posture, the act of speaking, whether you have recently eaten, whether you are anxious about having your blood pressure taken, whether the room is cold, whether you arrived hurrying. Blood pressure responds to all of it, continuously, in real time. Research published in the American Journal of Hypertension has demonstrated that blood pressure variability, the degree to which readings fluctuate across a day, is itself an independent predictor of cardiovascular events, separate from and in addition to average blood pressure levels. Meaning it is not just how high your blood pressure goes that matters, it is how much it moves, how dramatically it spikes, and how well it recovers. A single clinic reading captures none of this. It captures one frame from a continuous film and presents it as the entire story. The clinical term for what happens when that single reading is taken in a medical setting is white coat hypertension, a well-documented phenomenon in which blood pressure rises measurably simply due to the stress and anxiety of being in a clinical environment. Studies suggest that somewhere between 15 and 30% of people diagnosed with hypertension in clinical settings may have normal blood pressure in their everyday life. That is an enormous proportion. But the inverse problem is equally serious and considerably less discussed: masked hypertension, in which blood pressure appears normal in the clinic but is significantly elevated during the rest of daily life. Research published in the journal Hypertension has found that masked hypertension carries a cardiovascular risk comparable to sustained hypertension, yet it is missed entirely by clinic-based measurement alone. This is not a marginal edge case, this is a systemic problem embedded in the standard way that blood pressure is assessed in most healthcare settings around the world, and it affects the accuracy of diagnoses and the adequacy of treatment for millions of people every year. To understand why this mistake is so consequential, it is necessary to understand something about the biology of blood pressure elevation, specifically why the body is so extraordinarily effective at concealing the damage it is causing for so long. When blood pressure is chronically elevated, the cardiovascular system does not simply break down immediately. It adapts. The heart, which is a muscle, responds to the increased workload of pumping against elevated resistance by thickening, a process called left ventricular hypertrophy. The blood vessel walls, subjected to years of higher than normal pressure, remodel themselves, becoming stiffer and less elastic. The kidneys, under sustained pressure load, gradually lose filtering capacity. The small blood vessels supplying the brain, the retina, and the peripheral tissues accumulate progressive damage. All of this happens silently, compensated for by the body's remarkable capacity for physiological adjustment, with no symptoms, no warning signals, and no subjective experience of anything being wrong. This is what physicians mean when they call hypertension the silent killer. It is not silent in the sense of being rare or hidden from diagnostic view. It is silent in the sense that the body actively compensates for it, masking its own deterioration until the compensatory mechanisms are exhausted and the clinical event occurs. By the time a hypertensive stroke happens, or a heart attack, or the kidney failure that makes dialysis necessary, the damage was not recent. It was years in the making, building quietly in vessel walls and organ tissue while the person felt entirely well, and their occasional clinic readings offered them periodic, misleading reassurance. A landmark paper in The Lancet, part of the Global Burden of Disease study, identified high systolic blood pressure as the single leading risk factor for death globally, above smoking, above high blood sugar, above all other cardiovascular risk factors measured, not one of the leading risk factors. The leading one, and the primary reason it retains that position, despite being treatable, is the combination of underdiagnosis, misdiagnosis, and inadequate monitoring that flows directly from the single reading problem described above. There is now a substantial and consistent body of evidence establishing that home blood pressure monitoring, performed correctly and repeatedly over time, provides a far more clinically accurate picture of a person's true blood pressure profile than isolated clinic measurements. Guidelines from major cardiovascular bodies including the European Society of Cardiology, the American Heart Association, and the British Hypertension Society now formally recommend home monitoring as a standard component of hypertension diagnosis and management, not an optional supplement to clinic readings. But the critical qualifier here is performed correctly. Because the second dimension of the blood pressure measurement mistake, layered on top of the single reading problem, is that most people who do measure their blood pressure at home do so under conditions that systematically distort the results. They measure immediately after exercise. They measure after coffee. They measure while sitting on the edge of a bed with their arm unsupported and their back unsupported in a position that can artificially elevate readings by 10 millimeters of mercury or more. They measure once, note the number, and form a conclusion. The validated protocol for home blood pressure monitoring, as established in the research literature, requires the following: sitting quietly for 5 minutes before measurement, back supported, feet flat on the floor, arms supported at heart level, no caffeine, exercise or smoking in the 30 minutes prior, bladder emptied, no talking during measurement. 2 readings taken 1 minute apart, morning and evening, for at least 4 to 7 days. The average of these readings, excluding the first day, constitutes a reliable home blood pressure estimate. Very few people follow this protocol. Not because they are careless, but because nobody has ever explained to them that the conditions of measurement are as clinically significant as the measurement itself. A reading taken incorrectly is not just slightly inaccurate, it can be wrong enough to lead to entirely incorrect clinical conclusions, either falsely reassuring someone whose blood pressure is genuinely elevated, or falsely alarming someone whose blood pressure is genuinely normal. There is a third dimension to this mistake that operates in the population of people who have already been diagnosed with hypertension and placed on antihypertensive medication. And it is perhaps the most consequential of all because it affects people who are already in the healthcare system and who therefore have the greatest reason to assume they are protected. Antihypertensive medications are highly effective at controlling blood pressure when taken consistently at the right time every day. They are substantially less effective and in some cases clinically inadequate when taken inconsistently. The research on antihypertensive adherence is sobering. A systematic review published in the Journal of Hypertension found that somewhere between 40 and 60% of patients on antihypertensive therapy are non-adherent within 1 year of starting treatment, meaning they are taking their medication irregularly, missing doses, or stopping entirely without informing their physician. The reasons for this are entirely understandable. The medication controls blood pressure, which means the person feels no different on the days they take it compared to the days they do not. There are no immediate consequences to a missed dose that are perceptible to the individual. In the short term, non-adherence is invisible. The damage it permits is accumulating exactly as silently as untreated hypertension itself. And because clinic visits are infrequent and readings are taken at a single point in time, the clinical picture may not reflect the reality of how blood pressure is behaving on the days when medication was skipped. This is compounded by a phenomenon called therapeutic inertia, the tendency of both patients and clinicians to accept blood pressure readings that are higher than the recommended target without escalating treatment. Research published in the Journal of the American College of Cardiology has identified therapeutic inertia as one of the principal reasons that hypertension remains inadequately controlled in such a large proportion of diagnosed patients. The reading is elevated, the patient feels fine, the medication was adjusted last year, and changing course feels premature. Meanwhile, the vessel walls continue their silent remodeling, and the risk continues its quiet accumulation. Even among people who measure blood pressure consistently and take their medication reliably, there is a fourth, less well-known dimension of this mistake, one that relates specifically to when blood pressure is measured and how that timing interacts with the body's natural circadian rhythm. Blood pressure is not uniform across a 24-hour period. It follows a predictable daily pattern, lowest during deep sleep, rising sharply in the early morning hours before and after waking, a phenomenon called the morning blood pressure surge, and fluctuating throughout the day in response to activity, meals, stress, and posture. In most people, the early morning hours represent the peak of blood pressure across the entire day, and this peak is physiologically significant. It is the period during which the risk of cardiovascular events, heart attacks, strokes, and sudden cardiac death is statistically highest. Research published in the journal Circulation has consistently shown that the majority of acute cardiovascular events cluster in the 2 to 4 hours following waking, directly correlating with the morning blood pressure surge. Now consider what this means for someone who measures their blood pressure in the early evening before taking their medication and uses that reading as their primary reference point. Evening readings taken after a day of normal activity often represent one of the lower points in the daily blood pressure profile. They may appear well controlled, they may be genuinely reassuring by the numbers, but they tell nothing about what blood pressure was doing at 6 in the morning when it was at its peak and when the cardiovascular system was under its greatest daily load. A medication that brings evening blood pressure to an acceptable level does not automatically provide equivalent control at the morning peak, particularly with longer-acting medications whose concentration in the bloodstream may be at its lowest precisely when the body needs it most. This is not a theoretical concern. Research comparing ambulatory blood pressure monitoring, which captures readings across a full 24-hour period automatically with standard clinic home readings, has found that a meaningful proportion of people who appear well controlled by conventional measurement have uncontrolled morning surge profiles when assessed continuously. This is a population at genuinely elevated cardiovascular risk, whose risk is invisible to the monitoring strategy being used to assess them. The picture that emerges from all of this is not complicated, but it is important, and it is worth stating clearly. Millions of people are making a blood pressure mistake that is not a failure of willpower or intelligence or access to information. It is a structural mistake embedded in the way blood pressure assessment has been normalized. The assumption that a single reading taken under uncontrolled conditions at an arbitrary time of day provides a reliable basis for clinical decision-making. It does not. It never really did. And the gap between what that reading shows and what the cardiovascular system is actually experiencing is, for a significant proportion of the population, the gap in which the silent damage accumulates. The practical response to this begins with understanding that blood pressure management is a longitudinal exercise, not a periodic one. A reading matters far less than a pattern. A pattern requires repeated measurement across multiple days and times under consistent conditions using a validated device. The British and Irish Hypertension Society maintains a list of clinically validated home monitors, as do equivalent bodies in other countries, and the difference between a validated device and an unvalidated one can be clinically significant. Using the right equipment under the right conditions at the right times, including morning measurements that capture the peak period, is the foundation of accurate self-monitoring. For those already on antihypertensive medication, consistency is not optional. The protective effect of the medication is a function of its sustained presence in the bloodstream, and that sustained presence requires daily adherence without exception. If side effects are making adherence difficult, that is a conversation to have with a physician, because the range of antihypertensive options is broad, and finding a well-tolerated regimen is almost always possible. Stopping or skipping medication because blood pressure feels controlled is precisely the logic that the silent nature of hypertension makes so dangerous. It feels controlled because the medication is working, and removing the medication removes the control. Silently, invisibly, until the consequences become visible. For those who have not had their blood pressure formally assessed, or who have had it assessed only once or twice in clinical settings, the case for proper home monitoring has never been stronger. Devices are inexpensive, widely available, and simple to use. The investment of 10 minutes per day over 1 week following validated protocol generates a blood pressure profile that is meaningfully more informative than any single clinic reading. That profile, shared with a physician, gives both parties something genuinely useful to work with. And perhaps most importantly, for anyone reading this who falls into that very large group of people who know their blood pressure is slightly elevated, who have been meaning to address it more seriously, who feel well enough that the urgency has never quite crystallized into action. This is the moment to let it crystallize. The emergency medicine reality is unambiguous on this point. By the time the urgency becomes impossible to ignore, the conversation has shifted from prevention to recovery. And recovery from a hypertensive cardiovascular event is a considerably harder road than the one that leads away from it. The biology of silent damage is not waiting for a convenient moment. It is proceeding right now in vessel walls and heart muscle and kidney tissue, in people who feel completely fine. The measurement is not the protection. The pattern is the protection. The consistency is the protection. And understanding the difference between the two, understanding precisely what a single reading can and cannot tell you about your cardiovascular health, is not a minor technical correction. It may be the single most important thing you learn about your blood pressure today.